So who is responsible for our obesity and diabetes epidemic? Is it the individual or the disinformation supplied to the population? I used to get cranky at fat people. I used to get cranky with myself when I was 20 kilograms heavier than where I am now. And it becomes obvious over time that there is so much deliberate misinformation keeping everyone confused. So what happens when you ignore the disinformation? You find some individuals have done just that. Queen Elizabeth is a low carber. She's completely switched on and has been eating predominantly fresh, local and seasonal and minimal white foods forever. Does the Queen have type 2 diabetes? No. So type 2 diabetes is a lifestyle-related disease. It does not have to be a chronic progressive disease, nor does one have to take more and more medication. And the complications of type 2 diabetes are completely avoidable, and it's simple. And that's what I'm going to do today. A surgeon's simple perspective on some of the science and treatment options. But please remember, I am the only doctor in Australia that is not allowed to advise my patients to avoid sugar, even if that is best practice. So please take this talk with a pinch of salt. Let me try and simplify this huge topic with that piece of toast that some of you have in your hands today. We are eating, living and dying by the traditional food pyramid. And along the way, we are taking on the shape of it. The health system is bursting just like our waistlines, and our nutrition is both the problem and the answer. The true incidence of type 2 diabetes is unknown. It was estimated to be around 8.5% in 2014. The World Health Organization puts that at 422 million, up from an estimated just over 100 million 30 years ago. Poorer nations are faring worse as per the darker colours on the world map. 1 in 2 undiagnosed, particularly in poorer areas, probably the same number again with pre-diabetes. An estimated 12% of healthcare dollars are spent worldwide, and the increase in global health expenditure on diabetes will exceed the global population growth over the next 20 years. 1 in 4 health dollars were spent on people with diabetes last year in the United States. Diabetes cost $327 billion, with at least $90 billion in lost productivity. An Australian is diagnosed with diabetes type 2 every 5 minutes. 1 person dies every 6 seconds worldwide as a result of diabetes complications. At least 1 in 6 pregnancies are affected by hypoglycemia. The extent of the problem is likely to be grossly underestimated. The statistics are just staggering. We are told by the World Health Organization and virtually every diabetes association that diabetes is a chronic progressive disease. This is absolute nonsense. There's a 4-letter word there, I didn't use it. It does not have to be a chronic progressive disease. Type 2 diabetes is a preventable condition, and the complications of type 2 diabetes are entirely avoidable. And that is simply what this talk is about. This is my working definition for all types of diabetes, type 1, type 2, gestational diabetes. It's the inability to effectively metabolize the load of glucose entering the body. Nobody has a chronically elevated blood glucose without food being the central issue. Stress and drugs may push it up in the short term, but chronically elevated blood glucose levels come from what we eat. Too much carbohydrate results in an elevated blood glucose level. Variable levels of that blood glucose elevation end up in the tissue, and the chronically elevated blood and tissue levels of glucose cause the complications of diabetes. So how does that fuel, and specifically glucose, get into the body? So I'm going to digress to a wood fire. A fire burns wood. In that fire you can put in kindling, branches and logs. And kindling means you get up, opening and shutting the door. It's hard work fueling a log fire with kindling. Logs keep on burning slowly and branches are somewhere in between. And the same thing happens with what our body burns as fuel. So we need to do a little bit of basic biochemistry. Our cells require fuel and the mitochondria are the engines. The mitochondria convert fuel into ATP, that's adenosine triphosphate, which energises the metabolism of a cell. The wood of a mitochondria is acetyl-CoA. It is not glucose nor ketones. And that acetyl-CoA can come from a variety of sources and turn it into energy for our cells. Those mitochondria are the ultimate hybrid engines. The acetyl-CoA can come from the glucose and carbohydrates, the ketones from fat, or the amino acids from protein. So what does that effectively mean? Well, the carbohydrate is like kindling. It gets burnt quickly and needs replenishing. Putting more glucose in requires the fire door to be open and shut. That's the pancreas secreting insulin. And over time, that door just wears out. Welcome to type 2 diabetes. That's the simple form of Paul's explanation in the last talk. Proteins are like branches and burn slower, and healthy fats burn slower again, and you need less trips to the fire. So all carbohydrate is made up of glucose or fructose or combinations of those two. There is no human biochemical necessity for eating carbohydrate. No biochemical pathway is dependent on ingested carbohydrate. The small amounts actually required of glucose and fructose can be synthesised from other pathways like gluconeogenesis and the polyol pathway, and that's in another one of my talks. Glucose is half of sugar, the other half is fructose. Bread, rice, pasta, cereals and potato are just glucose carbohydrate. The starches, maltose, lactose and dextrose are just repeating chains of glucose. The longer they are, they become complex carbohydrate, but they are just simply glucose. Fructose is found combined with glucose in sugar and fruit. Glucose has a well-described metabolism. It's absorbed from the gut, it goes straight to the brain, and the glucose then goes to muscle under the influence of insulin, and any extra is stored as glycogen initially, but mostly as fat. There are about 4 grams of glucose in the blood at any one time. 1 teaspoon of storage is about 4 grams. Anything above that effectively goes towards fat storage, and what you do not use immediately gets stored as that glycogen and fat under the direct effect of insulin. So 1 slice of bread has about 5 teaspoons of glucose in it. That's 1 for the blood and the other 4 to be stored as fat. An average bowl of pasta has about 14 teaspoons of glucose, 1 in the bloodstream and the rest are fat. Same goes for a bowl of rice. A medium-sized potato has around 6 teaspoons of glucose, 1 for the blood, 5 towards fat storage. So remembering that diabetes is that inability to metabolise the load of glucose entering the body. There are 2 types of diabetes in general. Type 1 is an autoimmune condition characterised by not producing enough insulin. And type 2 people have developed a resistance to the insulin they produce themselves. The traditional thinking has been to increase insulin availability, to give insulin. And that might be okay for type 1, but it just doesn't make sense if you've got type 2. Why give more of something when you are resistant to it in the first place? We don't give more of the same antibiotic to a patient with a resistant infection. We look at alternatives. So no wonder we are failing to control the epidemic when the basic reasoning is flawed. So we have 2 options in the treatment of diabetes. You can continue with the same intake of glucose and move that glucose around with drugs, or you can reduce the glucose load and not need to move any glucose around. That means no drugs. So let's compare the 2 options. Medications just move glucose around. It's a bit like moving deck chairs on the Titanic. Ultimately, that's a disaster and becomes a chronic progressive disease. So I think those drugs fall into 3 groups, and we can probably get rid of all of them with the right dietary advice. The common drugs like metformin and insulin push more glucose into the tissues, remembering that the tissues are already full. Some drugs aim to stop us from absorbing glucose from the gut, but how about just eating less glucose? And some drugs increase the urinary excretion of glucose. Insulin is that drug which you are told will be required as diabetes is a chronic progressive disease. It's just a matter of time. The problem with insulin is that it converts glucose to fat. That means more fat storage when you eat carbohydrate. And most people with diabetes put on weight when they start insulin. That's part of the overall disaster. Insulin is also a growth factor, and that can stimulate cancer. The other option in diabetes treatment is to stop eating carbohydrate. It's not an essential nutrient. The tissues are already saturated, and it's time to empty the tissues of excess glucose and fat. I think of diabetes along the concept of a nut allergy or an intolerance. Who here will knowingly encourage children with a nut allergy to eat peanuts and then give them adrenaline to keep them alive? You know the allergic reaction to the nuts can kill them. So why on earth do we encourage people with diabetes to consume carbohydrate and then tell them to have more medication? I think diabetes is an allergic reaction to the glucose that will kill you just as effectively as a nut allergy, but in a much slower way. Diabetes is a carbohydrate intolerance, nothing more or less. Eating carbohydrate and chasing it with medication makes the blood glucose go up and down like a never-ending roller coaster. There are a few health bureaucracies in the front that think that's a good idea, but the rest of us are sitting in the back, terrified, riding along the way. Current diabetes recommendations keep saying have plenty of carbohydrate and chase it with that medication, and that is just rolling the dice between glucose lows and highs. And let's talk about those lows and highs. Hypoglycemia means a low blood glucose. It is generally related to too much medication or too much insulin. It is not a matter of not eating enough food. The symptoms are agitation, lightheadedness, and sweating. And there are not really any long-term complications of running low unless the very rare situation of going into a coma state. And the cause of that is generally caused by too much medication. The cause of hypoglycemia is either too much insulin or too many tablets. It's not about the food. Avoid hypos by having less medication to drop your blood glucose. Hyperglycemia is an elevated blood glucose and all related to eating too much food. The highest blood glucose tend to follow meals, and that's the time when long-term damage occurs. Where does it come from? It comes from eating too much carbohydrate and not producing enough insulin or not taking enough medication to cope with the carbohydrate eaten. Wouldn't it be better to just eat less carbohydrate? The complications of too high a blood glucose can either be acute or chronic. And we'll explore those. Acute complications include agitation, fatigue, thirst, and increased urine output. And in extreme situations, hyperosmolar syndrome for type 2s and ketoacidosis for type 1s. These people are generally ill from other problems. Neither of these states are nutritional ketosis. Nutritional ketosis is a perfectly normal metabolic state that we can drift in and out of when you skip meals or fast. So what are the chronic complications of blood glucose being too high? Organ damage is caused by advanced glycation end products, and I'll come back to this. The damage over time is directly related to chronic disease, organ failure, and ultimately death. So how do advanced glycation end products cause damage? I want to talk about toast, and that's what this is about here today. Okay? We've all seen the browning of toast, cakes, and cookies. And that's called the Maillard reaction. Glucose binds to protein, and under the effect of heat, the toast goes brown. The same thing happens in your tissue. High glucose levels combine with the protein, and under the effect of body heat, the Maillard reaction takes place. That reaction makes tissue stiffer and ultimately inflamed. So every time your blood glucose spikes, you are effectively toasting your brain, your eyes, your kidneys, your vessels, your tissues. And this toasting is occurring in every organ of your body. Welcome to the complications of poorly controlled diabetes. Glucose oxidation also occurs with lipids and fat at high glucose levels. And there's also a polyol pathway conversion of glucose to fructose, releasing highly inflammatory oxygen-free radicals along the way. They have the same effect as advanced glycation end products. And that polyol pathway is covered in one of my other talks, which you might have seen on the nutritional model of inflammation and modern disease. The common test for diabetes control is the hemoglobin A1C, HbA1c. It's a measure of the damage done by those advanced glycation end products on erythrocytes. The raised blood glucose has a direct effect on our red blood cells. It's a measure of damage, it's not a measure of control. So what do those advanced glycation end products do? They account for organ damage at the tissue level, at every tissue level. They can affect the brain, causing issues from dementia, now being considered as type 3 diabetes, through to mental health and strokes. It's a mechanism causing diabetic retinopathy and macular degeneration, peripheral vascular disease, heart attacks, kidney failure, peripheral neuropathy, foot ulceration and amputation, infection in all of its forms, and cancer. End organ damage is what kills you. Slowly we die, not immediately like the nut allergy, but just as effectively. So how do we become aware and diagnose diabetes? Well, first of all, by the symptoms of high and low blood glucose levels. We can test urine, we can do blood tests, that includes fasting glucose levels, the HbA1c test. Insulin levels are becoming topical, or a glucose tolerance test, which is often used in equivocal situations. The most sensitive test is to do the serial insulin levels after a glucose load, named after Joseph Kraft, but rarely done. If done on everyone, it will reveal that about 3/4 of the community are likely to be at risk of diabetes. The hemoglobin A1c. This is the current standard test for diagnosis and a monitoring test. It is a measurement of blood glucose control or damage over the previous 3 months. It is a measure of that damage to the red blood cells caused by the advanced glycation end products. A normal HbA1c is classed as less than 5.7% of red blood cells being damaged. So where did that percentage come from? Are those percentages that we refer to relevant in view of current literature? Diabetes is diagnosed as being above 6.5%. So what about that group in between, 5.7% to 6.49999999? Well, that group's said to have pre-diabetes. They should not be called pre-diabetic at all. They have early diabetes. And doctors tend to say to that group, be careful, do some exercise. Well, we know that's hopeless. Studies show that that group there is actually already in trouble. That is the group that can avoid full-blown diabetes by adopting a low-carbohydrate lifestyle. From the surgical perspective, this is a group to be aware of. About 1/3 of patients fall into that category when you consider that 2/3 of the adult population are overweight or obese. Those patients have higher complication rates and a higher incidence of post-operative death in some studies. So what does the medical profession aim for in controlling diabetes? Should it be less than an arbitrary 7% or 8 or 9%? Why don't we aim for normal HbA1c? Why do we have goals to make people only a little bit better? So what happens if your HbA1c is above the normal? The risk of cardiovascular disease increases above 5.5%. 6.5% might give you that diagnosis of diabetes, but you are way out of control even at diagnosis. Coronary heart disease risk goes up above 5.5%, so does stroke risk, and death from any cause goes up above that 5.5%, not 6.5% or the control number of 7%. So the pre-diabetics are in trouble, yet professionals continue to say, don't worry, just be careful, go out and outrun your bad diet. Having a HbA1c above 6% is also associated with cancer risk. People with diabetes are well known to be at a higher risk of cancer. Cancer is directly tied up with glucose and insulin metabolism. That HbA1c is used as a measure of control, but may just need to be reconsidered. We should be aiming at control at less than 5.5%. Are we likely to get there with our current recommendations? Not likely. Carbohydrate intakes are currently being revised, but are still recommending about half of our energy to be intake as carbohydrate, and reminding us along the way that the brain is entirely dependent on glucose. That glucose needs to be then chased with medication, and the link between carbohydrate intake and poor control has been known for decades. Carbohydrate counting has variable results and most of them poor, and we have failed to learn from that. Carbohydrate load is associated with obesity, up go the rates of cardiovascular disease, and up go the rates of cancer. How does our community fare on those current carbohydrate recommendations? Well, badly. This group of 349 people with type 1 diabetes were followed over 15 years. They follow the diabetes guidelines just like type 2s. And over 90% do not achieve an HbA1c under 7%, let alone 5.5%. So what happens if we reduce carbohydrate intake? How much you reduce your carbohydrate varies from person to person, and if you avoid the carbohydrate, everything improves. Low carbohydrate adopters reduce their medication. They actually do not need to move glucose around anymore. Without the glucose load, the requirement for insulin drops immediately. Weight starts to come down. Richard Bernstein's rule of small numbers comes in here. Small amounts of glucose require smaller amounts of insulin, therefore less highs and lows. Hypos virtually disappear as less medication is being taken. Safety improves. Blood glucose levels stabilise, and low carbers have worked out that they do not want to be on the roller coaster. They have taken back control. Some people with diabetes decide to go very low in their carbohydrate intake into a ketogenic diet. They cut their carbs to around 20 to 50 grams per day. They are in nutritional ketosis, not ketoacidosis. They again have taken back control. The roller coaster of blood glucose is finished. They will never go back to carbs. Just ask them. In fact, ask the CSIRO, because they published those results in 2015 and in their best-selling low-carb diet book in 2017. And it was an honour to have Penny Taylor, who was one of the authors of that book, stay with us and release the CSIRO results a couple of years before. And Penny and I were discussing concepts in that book, but I'm not allowed to talk about it. Other groups are reporting the results in type 2 diabetes. Virta Health are publishing their 12-month sustained results with their low-carb management. They are showing sustained benefits in comparison to traditional diets, reductions in weight, HbA1c, insulin levels, inflammatory markers and medication requirements. Their latest study on cardiovascular outcomes in patients running low carb with type 2 diabetes was published just this week with favourable outcomes. Some of you may know of the type 1 grit group. I'm proud to say I was there right at the beginning of them. And this group now support over 20,000 followers running low or very low carbohydrate for their type 1 diabetes. Their results are outstanding. I mention them because if you can control diabetes in this group, then controlling it in type 2 diabetes should be a piece of cake. So on Monday, this coming Monday, a paper will be published in Paediatrics. It's currently under embargo, but I've been privileged to be given an update on what's happening. Harvard looked at over 300 people running very low carb for their type 1 diabetes, children through to adults. Their carbohydrate intake was in the range of 20 to 50 grams per day. Their average HbA1c was 5.57%. That means they are normal. That is unheard of in type 1 diabetes management, and that puts that group in the best performing 0.5% in the world. 97% of their participants bettered targets. Carbohydrate intake was the only predictor of HbA1c. Lipid profiles were good, with triglycerides down and high-density lipoproteins up. They were not short and stunted. One of the comments is that they did it the hard way. They did it without professional support. But that group are hoping for normal life expectancy and avoiding complications, and they might just do it. And if they can do it, we all can. So what does the future hold for low-carb, healthy fat living in diabetes management? Well, you can improve your health today. It is there right now for the individual. Once you see the results, you cannot unsee them. Low carb in diabetes care has to become adopted by advisory panels, and if they do not adopt this soon, then a class action is coming. People with their own results are already calling for that. Low carbohydrate adopters with diabetes have worked out that they are just as allergic to carbohydrate as those that are allergic to nuts. It's just a time frame difference. Forget the CSIRO. Even Women's Weekly now has 3 low-carb cookbooks out. But I'm not allowed to recommend a low-carb, healthy fat lifestyle to my patients, but you can do it for me. So for me, I do not want my brain toasted. I'm going to continue my low-carbohydrate, healthy fat lifestyle for life. Thank you.